simultaneously logged into the YouTube as well, because I think the first session is being streamed live on YouTube, and this is for everybody. Yeah, good evening, everybody. I can see 5 people. Medha, Bhartiya, Arshi, Saurabh. How are you doing, guys? Simultaneously. Okay, I'll just reduce my voice on the YouTube. Yeah. Good evening, everybody. I think the first session is free for all, so we'll just wait for a couple of more minutes, isn't it? Obviously, our own students are still actively joining in, I guess. How are you doing, guys? How many of you are... Good evening. How many of you are new to the system and who have not taken my dental materials classes, and how many of you have taken? Have all of you taken my dental materials classes as well? I think we did them in June first week. Hi Priya, hi Garima. Yes, am I audible? Good evening, guys. Good evening. Good evening, Shantanu. Akanksha. Okay, Priya, you're new. You've taken. Some people have taken. Some people have not. So that means we have new admissions as well. Wonderful. Good. Guys, okay, yeah. Good question, Siddharth. Obviously, the basic outline will remain the notes, but this time what we've done is we've applied a lot of diagnostics. But what I mean by applying diagnostics is that we've analyzed the last 5 to 10 years of papers, and apart from keeping in line with the concepts, we've also analyzed that sometimes, there are questions which are coming from relatively unimportant, seemingly unimportant topics. So what I've done is this time I'll also be covering, apart from the concepts, but also be covering all the previous year questions and the topics. I've kind of incorporated them in the narrative of the lecture, right? So aisa hai. So you can keep your notes handy, but please do have your paper and pen with you, because I'll be telling you some very important additional points which were not just restricted to, your notes or your core curriculum, which we've analyzed in depth and realized that, what all other important things questions are asked from, right, guys? Okay, great. Good evening, Marinder. Good evening, Kankan. Yeah, Kankan, you were there. Good evening, Saksham, Dr. Radha. Hi, Pavitra. Wow, wonderful. You're from Kerala. So I've been to Kerala. Last batch also I told I've been to Kerala back in the year 2000. I was in school. So I covered Kovalam. We did Alleppey. I visited Munnar. Wonderful hill station. Great. The introvert. Arey bhai, apna naam dalo. Good to see you guys. Wonderful. Good evening, Nandini. I'll be telling all the topics. Yes, of course, Tanvi. Post and core is like a dedicated topic. I'll be covering that separately. And that's the favorite. Trauma and post and core are the favorite of the INI, basically the favorite of AIMS people, right? Good. Aparna, you guys are still joining in. Come on, guys. I'll just wait for 2 more minutes and then I'll start, right? It's already 6:05. I'll wait for a couple of more minutes and then I'm going to start, guys. Ayush. Good evening, guys. Good evening. Khushbu. Yep. Good evening. All right, great. Raj, good evening. Yep. So guys, I'm starting the lecture now, okay? Obviously, I think if you have your friends who are still joining in, see, Guys, basically this first session is going streaming live on YouTube for everyone. So I'm right now in my phone, I'm logged into the YouTube link, and I'm not logged into the Telegram group. So if people are rushing in and wanting to join very fast, guys, please tell your friends in the next 1 minute. Everybody please join in, because if you join late and then you break the momentum of the class, right, break the narrative, then I have to repeat all these things again and again, and so on and so forth, right? So I really don't know how many of our DBMCI students are still waiting, not joined, because I am directly on the YouTube link, right, guys? Yes, all of you are there, all of our students, and welcome everybody else who's wanting to, who's contemplating joining DBMCI, whether yes, whether no, and want to taste some initial tea before finally buying the entire packet, right? So, okay. Siddharth. Okay, let's start with Acha. So, Siddharth, wonderful. Good evening, Siddharth. Wonderful. You play basketball? Good. Okay. So, guys, I'm Dr. Aishvarya Kaushik, and all of those who are new to this, I'm Dr. Aishvarya Kaushik. I'm your faculty for Endodontics, Conservative Dentistry, and Dental Materials at DBMCI. I myself am an endodontist. I have my practices at New Delhi. I am from Maulana Azad Medical College, did my graduation, post-graduation, senior residency, and pool officership. I spent about 15 years in Maulana Azad Medical College, New Delhi. I've written a book called The Textbook of Endodontics. It's available freely online. And yes, so that's all about me, right? And now, guys, we are looking at covering the entire endocons in about 7 to 8 sessions here. And even if I'm averaging 3.5 hours on the weekdays and say a Sunday 4 hours, I realize that many a times when we break for a tea or say lunch during Sundays, we say about 20-25 minutes, but I'm calling everybody back, right? And that takes another 10 minutes. So effectively, what I feel is we have 21, 22, 23 hours at the best to cover this entire syllabus. Now tell me, is it possible? Yes and no. Why no? Because obviously, I mean, doing the entire Cohen, Ingle, and Sturdivant, right? Doing the entire Cohen, Ingle, and Sturdivant with a hint of Summit Robbins, with this hint of Grossman here and there, is just impossible. I always prefer live classes, dear. It's just impossible. So what is the mechanism going to be like? Why did I say yes and no? No, because doing it in a linear manner is practically impossible. It's not even possible in 50 hours, right? But why do I say yes? Because I have devised a way specifically for you, customized the content in a manner in which I'll be telling you the concepts, but I'll be coupling them with whatever important things that have come in the previous 10 years, right? That's one thing. So that's known as what do you call as diagnostics. You read the entire Sturdivant and you realize that 90% of the questions are coming from 20% of the book, right? The rest 80% of the book covers only 20% of the questions, right? So we are going to rely on what is coming as eventually MCQs, right? So it's like, this is what we call PYQs and PYTs, previous year topics and previous year questions, right? But at the same time, yeah, yeah. But at the same time, yeah, so that's why. But I mean, after all, we are not here to replace your 4 years of BDS, right? We deem it, we feel that you've read something in your BDS. That's why you're interns and post interns, right, guys? So anyways, that's one. Second, the first topic that we decided to take, always we take endodontic diagnosis, but that eventually becomes the longest topic, and I'll tell you why. That's the second topic for today. But the first topic that we're doing here is working length determination, simply because it's small, it's interesting, and obviously 1, 2, or 3 questions are Oh, Raj, we are going to go for 100%. Don't worry. I'm going to be covering everything in these live classes. I'm not going to be leaving that 20%. Don't worry. I'm going to teach you in such a manner that all the questions are covered. Right? The entire koan or sturdiment won't be covered page to page, but all the questions will be covered. Don't worry about that. Right, guys? Fine. So the first topic for all of us here is working length determination, guys. Now, whatever is important only for your basic knowledge introduction, I'll be covering fast. And whatever is coming in the exam, I'll be giving some more time to it. Okay? Everybody is fine with English. I'm very good with Hindi, but I know people are there from down south, northeast, and they're like, it has happened before. वो कहते हैं कि sir English में बताओ सिर्फ. So I'm going to stick to English. I'm going to keep it simple. Right, guys? So working length determination is the first topic that we are starting with. Now, as far as the curriculum is concerned, what all is there, right? First is, what is the working length definition? Absolutely not asked in the exam. What is asked in the exam is that if you have a tooth, you've done your access preparation well, then where do you end your working length? Where do you end your cleaning and shaping? Where do you end your obturation, right? So you end your cleaning and shaping at the minor apical diameter, right? At the minor apical diameter, which is also known as the apical constriction, guys. That's one. Which is also known as the apical constriction. That's MCQ number 1. To determine canals in, I'll tell all of that, dear. That's apical constriction. That's MCQ number 1, dear. Please restrict yourselves to the questions that are relevant to the topic. Now, someone has asked, Dr. Roaster has asked me, I hope you won't roast me. You know, there was this roasting thing that started at MTV, right? 4-5 years back. Mujhe roast mat karna, please, dear. So you've asked me, sir, canal kaise prepare karna hai? Maxillary molar. That's tooth morphology, guys. Access preparation. When we do that chapter, we'll do it, right? Abhi, let us restrict ourselves to working length, right, guys? So apical constriction, that's MCQ number 1. The second is the apical constriction the same as cemento-dentinal junction? It can or it cannot be, right? Why? Because the portion where your cementum and the dentine, like cementum is lining the canal up to some depth, up to some distance, and where it meets the dentine here can vary across a given cross section of the canal. So there's no one point across the cross section of the canal where the dentine ends and the cementum starts. In fact, even in some cases it has happened that, you know, your dentine is actually extending to the external root surface and cementum is starting somewhere on the external root surface, right? So yes, ideally, yes, if there was a way in which I could end my cleaning and shaping and obturation at the cemento-dentinal junction, that would have been perfect. Why? Because it's a dentine that is infected. It is the dentine pulp complex that I'm dealing with when I'm doing a root canal treatment. But it is a histological landmark, cannot be determined clinically, number 1. Second, it varies across different levels. But for work, but one canal can have only one working length. You cannot have 2, 3, 4, 5 working lengths. Is that right, guys? Yes. So I'll tell you how we decide the apical constriction. So therefore, the MCQ number 2 is, that is the cemento-dentinal junction always corresponding with the apical constriction? No. So CDJ, which is a histological landmark, and it is like an aim which is never realized. If realized, it is by chance. That is the ideal way of doing your root canal cleaning and shaping, but it's not always realized. So cemento-dentinal junction may or may not be same as your apical constriction. Yes, guys? All right. Next important point. What is the other synonym of apical constriction? It is the same as minor apical diameter. It is the same as minor apical diameter. That's MCQ number 3, guys. That's MCQ number 3. All right. Now, if this diagram that I've made with my hand, if you are to get as an image-based question, you won't get it as I've made it with my hands, right? You will get it something like this, right? Yes. So, guys, this is the apical constriction or the minor apical diameter, and this is the apical foramen or the major apical diameter. And this shape is like the rays of the sun, right, diverging. This is known as morning glory, right? So the distance between, so the shape between the minor apical diameter and the major apical diameter resembles morning glory, simply because you feel great when you're, getting up early in the morning, going for a jog. The sun rays are diverging outwards. That's the morning glory appearance. Next MCQ. What is usually the distance between the apical foramen and the apical constriction? So that's your, I'll just standardize this so that I'll just keep my MCQs here, right? Now, what's usually the distance between the apical foramen and the apical constriction? The distance is 0.5 to 1 millimeters. 0.5 to 1 millimeters. That's your next MCQ. Right, guys? Yes? All right. Next point. Does this mean that from the radiographic apex, meaning that if I take an X-ray of, say, this tooth, right? Does this mean that my apical constriction will always be, so if this is the radiographic apex, right? Does this mean that my apical constriction will always be 0.5 to 1 mm short of the radiographic apex? No. The apical constriction is 0.5 to 1 mm short of the apical foramen, guys. And the apical foramen can be off center. You understand? So basically, see, if this is the magnified view of the root, all right, guys, this is the radiographic apex, yes, but the apical foramen is here, right? And the apical constriction is 0.5 to 1 mm short of the apical foramen. So that means that your apical constriction can actually be up to 3 mm short of the radiographic apex. You understand? Yes, guys. Good question. Right, so someone has asked on the YouTube that, sir, what is the difference between radiographic apex and anatomic apex, guys, or morphologic apex? You take out the tooth, you take out the, so this is an extracted tooth, right? The tip of the root is the anatomic or the morphologic apex, but when the tooth is inside the bone in the patient's mouth, you can only take an X-ray. Then the tip of the root is the radiographic apex, right? Sir and everyone, I'm Swapnil. Hi Swapnil, how are you? Right. Lakshita, Shabi, kya hua? So what did you ask me to repeat, guys? It's a flower. Right, so radiographic apex versus the anatomic apex. Is that what you want me to repeat, Lakshita? Shabi? Yes? Yes, Lakshita, is that what you want me to repeat? What do you want me to repeat, Lakshita? Acha, you want me to repeat the apical foramen? Okay, I'll repeat both the things. See, apical constriction is short of, see, I'll make it in a neutral color so that you understand it better. ये देखो, your Pavitra, your X-ray should not be distorted. All of this is considered that you're using a parallel cone technique, right? It's not how we do in college, right? So that's your Lakshita. Apical constrictor point, na? See, this is the radiographic apex. This is if this is the X-ray image, and this is the radiographic apex. Any doubt? This is the radiographic apex, right? All right, guys. Then this is my canal. Right? This is what? This is my apical foramen, right? This is my apical foramen, guys. This apical foramen can be short of the radiographic apex by about 1.5, 2 mm, right? And this is my apical constriction. This is my apical constriction, right? Yes. And this apical constriction is further 0.5 to 1 mm short of the apical foramen. So this is where, at the apical constriction, your working length ends. So that means your apical constriction from the radiographic apex can be up to 3 mm short, because your apical foramen may or may not coincide with the radiographic apex, and the apical constriction is further short of the apical foramen. Is that right now? Yes. Through the constrictions, they're all dentinal depositions. In fact, in some cases, there are multiple constrictions. There's not even one single constriction. That's why endo is so challenging, isn't it? You do everything right, still there is pain, isn't it? No, not necessarily, Astha. In root resorption cases, constriction may not be there. Yeah. So it's always safe to be, always 1 mm short of the radiographic apex. Simple. And always use, apart from the radiograph, use an apex locator. Is that right, guys? Dear, वही तो भी बताया कि apical constriction may or may not coincide with the CDJ. I told this before, right? If you joined just now. Tip of, yeah, exactly, Pavitra. Yes, everything has to end at apical constriction, dear. Everything. Irrigation, cleaning, shaping, obturation. Earlier, there was this concept that some sealer puff, if that goes in the periapical area, some sealer puff, some droplet of sealer, it is a good thing. You pat your back. That was 20 years back, that I've done a nice obturation. Presently, nothing has to go beyond the apical constriction. Ideally. Yes, there is one controversy in endo, that is patency filing, that you should go beyond the apical constriction, even slightly beyond the apical foramen, to ensure that no dentinal debris plugs or blocks the canal's exit and entry, right? But again, that is controversial. But as a general rule, everything stops at the working length. The working length is the apical foramen. Not necessarily, Ritik, the apical foramen may or may not coincide. If it is coinciding with the radiographic apex, then your working length is just 0.5 mm short of the radiographic apex. If it is not, then it can be 1 mm, 1.5 mm, 2 mm, 2.5 mm, 3 mm, 3.5 mm. That's where the role of the apex locator comes. Right? Yes. Yes, Ritik. Are we good till here, guys? All of you? समझ आ रहा है? Everybody? Yes, guys. Shall I proceed? Ritik, everybody. Wonderful. I'm proceeding, guys. So I hope everybody has understood what I've told you till now. Wow. Very good. Bahut badhiya. Good, good, good. Now, guys, I'm a poor dentist, right? I don't have this. I'm going to show this to you in detail. This is my apex locator. That's a Root ZX, considered the gold standard. I'm going to just, I'm going to be covering a very controversial question. That's why I got this from my clinic to the studios, just to show this to you and to tell you what exactly that question is. But before that, consider me a poor dentist. A poor endodontist. I don't have an apex locator. Right? I only have radiographs to reach my final working length. Yes, dear. Your GP cone should end at the apical constriction eventually. Master cone, if you're doing a warm vertical compaction, you keep it short because you're going to press it down. But final level is GP cone. Okay, dear. Dr. Roaster. Dr. Roaster, what's your name, dear? All right, guys. So I just have my Dr. Roaster. What's your name? Okay. Anyways, I'll call you Roaster only. Please don't roast me. Okay, guys. So I'm a poor dentist, and I just have radiographs at my disposal. So what are the radiographic techniques to determine the working length? Right? One classical technique is the Ingles technique, Dr. Ingles technique. Hi, Vijay. Okay, hi, Vijay. So one classical technique is the Ingles technique, and just a small disclaimer. The details of the Ingles technique have not been asked in the previous 5 to 10 years. We reviewed all the questions that have come, but it's a very, very classical technique. So just listen to it in a positive manner. Why positive manner? No need to memorize it. It's not been asked in the previous 10 years, guys. You should know it. It's one of the techniques. Ingles method. Okay? It's one of the techniques. It's one of the radiographic techniques still used, especially by poor dentists, right? Like me. So what's that, guys? Take a nice preoperative X-ray, right? Take your scale or ruler. Obviously, this technique was developed before the age of RVG. So, I mean, just extrapolating it to the RVG, you have the function of the ruler there. See the entire length of the tooth, right? As a safety factor, reduce 1 mm. Okay? So say, for example, the entire length of the tooth, as you can see here, is 23 mm. As a safety factor, measure your file stopper, put your file stopper at 20. किस बात पे बात आज निकला है सौरभ? At 22 mm, right? Put your file stopper at 22 mm. Put it inside the canal and take another radiograph. Now, if again the length of the entire tooth is 23 mm, or in other words, the distance between the tip of the file, that is the end of the file, that's somewhere here, guys, here, this one, right? And the tip of the root is 1 mm, bang on. That's your final working length. Both your preoperative x-rays were perfect parallel cone technique. The length was perfect, 23 mm. You reduced as 1 mm as the safety factor, 22 mm. You again took, you gave your LA, put your rubber dam, did your access prep, deroofed the pulp chamber, removed the pulp from the pulp chamber, put the length, put the file inside, exact 22 mm at the reference point, and you realize that the distance between the radiographic apex tip of the root on the x-ray and the tip of the file was 1 mm. Bang on, that's your final working length. But what if there is a discrepancy? If there is a discrepancy, means there was either some distortion in your pre-op x-ray or in your working length x-ray. What do? You can't do anything, right? Say, for example, your discrepancy was 1.5 mm, right? 100% you don't know, right? But you need to reduce the error. So what do? Now your length of the tooth becomes, now your length of the tooth becomes what? Your length of the file, you know, right? You put it at 22 mm. Ab discrepancy आई है, the discrepancy is 1.5 mm. So now the length of the entire tooth is what? 22 mm plus 1.5 mm, 23.5 mm. Now this is much more real, right? Why? Because the file length you measured on the with your own hands. The length of the file that you put was not measured on the x-ray, right? So that is definitely 22 mm, right? Now there's a gap of 1.5 mm, so you can say that with less error, there can still be error, because this x-ray can also be distorted, but less error. So 23.5 mm is the length of the tooth. Now you 23.5 minus 1, 22.5 mm. put your file, take out your file, measure 22.5 mm on your endo block or your ruler. Again, take your working length at 22.5 mm. Again, check. Now again, if there is a gap of just 1 mm, bang on, that's your final working length. If still there is a discrepancy, repeat. So when you keep doing it, you're reducing the error. Is that fine, guys? As I said, if you've got a basic idea, let us proceed, because this question hasn't been asked in the previous 7 to 10 years. But this is basically a very, very nice way of reducing the error if you are a poor dentist like me, right? Is that right, guys? Yes, Namrata? Yes, Saurabh? Is that right? कुछ समझ आया? Even if 80% समझ आया, it's okay. Wonderful. Yeah, trial and error. Keep on doing it till you achieve your final length, right? Still there can be some error, but you're still better than doing it in just one go. Wonderful. So that's one method, and that's your Ingalls method. The second method is your Grossman's formula. Again, in the previous 10 years, guys, this formula hasn't been asked. It's basically a ratio. What is it? What do you want to find out? Grossman's formula is, okay guys, wonderful. So all of you have understood at least 95% of the Ingalls method, and I'm very happy about it. Because in the previous batches, I used to tell that about 2 to 3 times. Oh, absolutely. But then that's okay, that's worth it, dear. Time consumption is more, but anything good takes time, isn't it? Anything good takes time, right? It's like, what? I finished my MDS in 2014. I'm a 2005 batch BDS, 2005 to 10. 11 to 14, I finished my MDS in endo. And it is only now after more than 10 years that I have 2 clinics in Delhi, right? Anything good takes time, right? Darshit, I'm sure you're not poor. Okay, what distortion, dear? So if you so this Darshit exact technique that you're using, you're not using a parallel cone technique, I'm sure. That's why your X-rays are distorted. Okay, anyways, jokes apart, Darshit. Basically, what is happening is, okay, for Darshit specifically, especially for you, dear, that's your tooth. I'm just going to simplify this, right, dear? That's your tooth, right? Let's just keep simple numbers. So that's my apical constriction. That's my tip of the radiographic apex, tip of the root. That's my coronal reference point. Okay? The total length of the root of the tooth is 20 mm. All right, on the pre-op X-ray, I take a safety factor of 1 mm. Geometric apex, I don't know, beta. I don't know. All right, I'll find out if there is any. All right, 20 mm, right? That's the total length of the tooth. As a safety factor, reduce 1 mm, measure your file, put your stopper at 19 mm, do your access prep, insert your file at 19 mm, take another X-ray. If the distance between the tip of the file and the tip of the root is 1 mm, you bang on. That's your final working length. But if it is not, if it is, say, the distance is, say, 2 mm, so that means the file that you've put inside the canal was what? Was 19 mm? That has to be 19 mm, isn't it? Because that's what you physically measured. But if the distance between the tip of the file and the tip of the root is 2 mm now, that means the length of the tooth is now not 20 mm, it's 21 mm, right? 19 plus 2, that's 21 mm. So you again take out the file and reduce 1 mm from 21 mm. So that becomes 20 mm. Then take another X-ray, again check. Now if the distance between the two is exactly 1 mm, fine. If it varies, then again adjust, again take the X-ray. Right, Darshit? Yeah, I mean, apex locators are very expensive, dear. Good apex locators, like Root ZX J Morita that I have, is costing you about 60,000 bucks, right? You have local apex locators coming at 10,000 rupees, but they're not good. It's better not to have an apex locator, right, Darshit? Okay, okay. Then another thing of, yeah, Garv, please do start your MDS prep. Start doing your MCQs. Okay. Grossman. So another thing of relative importance, again, not a question hasn't been asked in the previous 7 to 10 years, but it can be asked. It's important. So Grossman's formula is another radiographic method. What is this? What do you want to find, guys? Actual working length. That's your X, right? That's what you, not your X. That is, let it be X. You don't know it, right? So actual working length upon actual length of the instrument. You know the actual length of the instrument because you've measured it, right? And put it inside the canal, right? Is equal to the radiographic working length. What is the radiographic working length here? Your radiographic calculation of the working length, right? Yes, upon the radiographic length of the instrument, right? Because again, your X-ray can be distorted, right? So radiographic length of the instrument. That's the formula. What is the basis of this formula? That your X-ray may be distorted, but the ratios will be fine, right? Even if in a distorted X-ray, the ratios should be fine, right? So actual working length, so that's a way of memorizing this. Don't go into too much details, you'll get confused. So actual working length upon the actual length of the instrument is equal to the radiographic working length divided by the radiographic length of the instrument. So the numerator is the working length, the denominator is the length of the instrument. On the left hand side, it's the actual, and the right hand side is the radiographic. Just memorize this. Yes, again, as I said, question hasn't been asked in the previous 10 years from this formula. It's there in your textbook. No harm in knowing this. Right, guys? Am I fine? Have I given you a simple way of memorizing this? Left hand side, the working length or the length, the actual. Right hand side, the radiographic. Left hand side actual, right hand side radiographic. Numerator is the working length, denominator is the length of the instrument, right? Yes, guys? Yes. Yes, I think you guys, I don't know about the people who are not part of DBMCI. Nikhil, so we'll just slow down. Don't worry, Nikhil. This is basically the Grossman's formula, which is by which we are trying to reach the actual working length, which in reality nobody can. Only when you extract the tooth, section it, then only would you know the length, isn't it? Then only would you know the constriction, isn't it? Nobody can see the constriction, neither can you feel it, right? You can feel it in some cases, but again, you can have constrictions, multiple constrictions in a root canal. So it's all like practice and experience, right? And a combination of radiograph and apex locator. All right. Yes, dear. Bhartiya, yes. X-ray, if it is not distorted, you will get the final length in the first go only by the Ingles method, isn't it? If both your X-rays are fine. All right. So actual length, actual working length which you want to find divided by the actual length of the instrument is equal to the radiographic working length divided by the radiographic length of the instrument. The ratios don't lie, right? You can have a distorted X-ray, but the ratios would be more or less fine, right? That's the idea of this formula. Okay? Wonderful. I think many of you understood this. Wonderful. Again, this is a tough one to understand. I just made it simple by giving you a simple way of memorizing this, right? Just remember, numerator is working length, left hand side, and denominator is length of the instrument. Left hand side is actual, right hand side is radio, right? Then the third technique of determining the length, that's actually not a technique, that's a guideline, but it's in your textbooks very funnily, in a very funny, I don't know why, but even the foreign authors give this as a technique. And these are known as Weine's modifications. These are known as Weine's modification. What he said was, just like Ingle, you take an X-ray. If there is no root resorption, neither bone resorption, just reduce -1. Reduce 1 mm from the length of the tooth. Right? Just like Ingle said. But he also said that if there is root resorption, which is actually pretty common in non-vital cases, right? And if you can actually see it on the radiograph, then reduce 1.5 mm. Why did he say that? Because, you know, in root resorption, what happens is sometimes root resorption again is not equal throughout the circumference of the root, of the tip of the root. So sometimes there'll be more resorption on one wall, less resorption on the other, and you want your instrumentation and your gatta pacha to be well within the root, right? You don't want it to be saying hi to the periapical tissues from one wall, right? So with root resorption reduced by 1.5 mm, and when there is root resorption plus you realize bone resorption is also there, then reduced by 2 mm. That's the guideline. Again, this is of historical significance. Nowadays, you're not supposed to analyze all of this. You just see the X-ray, you take the working length with the apex locator also, and with your experience, reach the final length, right? So these are the Weine's modifications. Yep. Now, obviously, this question, if this comes, is going to come. If it comes as an image-based question, it'll come like this, right? So the first situation is actually what we discussed with the Ingle's method, right? Just reduce 1 mm from the total length of the tooth. Now, this is a situation in which there is some bone resorption, right? But no root resorption. Yeah, you're right, Akanksha. I think I just mixed the two. In the middle situation, not root resorption, actually bone resorption. So if there is only bone resorption, then reduce by 1.5. And if there is bone plus root resorption, then reduce by 2 mm. My bad, dear. Please correct this. Yes, Dr. Murari, it's completely blind. It's actually a blind procedure. Okay. So if there is bone resorption as well as root resorption, then reduce by 2 mm. If there is only bone resorption, reduce by 1.5 mm. Yes? Perfect. Is that right, guys? So the question that is going to come here is, all of the following are methods of determining the working length radiographically except. So you have to know this terminology, right? That there is one method which is known as the Ingle's method. Then there is a method which is known as Weine's modification. And then there is a method known as Grossman's formula. And then you can have a fourth option which can be ABC, XYZ. So you can have this question in which all of the following are radiographic methods of determining the working length except. Is that right, guys? That's not a situation. Prerna, that is not what Dr. Weine said, nor what he considered. We can't make up on our own. But I think basically, you know what the concept is. If root resorption usually is happening after bone resorption, you have a case of periapical granuloma, there has to be. You have a case of necrosis, there has to be some bone resorption. That's easier to get resorbed, right? With osteoclasts coming in. So whenever you have root resorption, bone resorption is always there. There are hardly any cases in which there will be root resorption but no bone resorption, right? So that's why we don't have that fourth category. TK, is that right, Prerna? Prerna only asked, na? Yes, Prashant. You are, I mean, these have scientific evidence, obviously. But as I said, your final working length would be reached by checking it out with the apex locator also. That's actually another MCQ. What is the best way of determining the working length? A combination of X-ray and working length. and apex locator. Where is Prerna? Prerna, is that fine? So if you have root resorption, there has to be some bone resorption. Yes. So you automatically the answer becomes 2 mm. Basically, that is a question, right? If the examiner tries to trick you into thinking that there is some confusion here, root resorption matlab root resorption plus bone resorption, answer is minus 2 mm, right? Yeah. I just, this is, यहाँ पे just correct this dear. This is bone resorption. I got wrong here. Bone resorption minus 1.5, root plus bone minus 2, right? Is that fine, guys? Yes. Yes, Pavitra. Bone resorption, only bone resorption 1.5, bone plus root 2 mm. This one. Absolutely. Blunderbuss is basically diverging open canals. We'll do that when we're doing traumatology. That's a tough one. How do you manage those blunderbuss? That's a Schweck's classification. That's a totally different thing. We'll do that, dear. It's a very, very important and controversial thing. We'll do that. Yeah. Okay. But since you've asked, Swati. Okay, good. So, guys, till now, where are we? We've discussed what the working length is. Where do we stop? What is the relationship of the apical constriction with the cemented dentinal junction and the apical foramen, and what is the relationship of the apical foramen with the radiographic apex? Then we've determined the poor man's method of determining the working length. These are 3 radiographic methods. That's Grossman, Weine, and Ingle, right? Now, one very classic MCQ, in fact, since Swati just told this, that's the paper point method. What's that, guys? Paper point method is done for open apex cases. Now, just Swati asked, sir, what is blunderbuss canal? Blunderbuss canal is an open apex. Are all open apex blunderbuss? Not really. You can have, see, basically, when you have the diameter of your apical foramen greater than 1 mm, according to some references, greater than 0.7 mm, according to another reference. But basically, you don't have an apical constriction, right? You have an open apex. When can that happen? When the root formation is not complete. That is in immature teeth, like a child of 8 years, his upper central incisor just erupted 1 year, 1.5 years back. The root end maturation will take another 2 to 3 years, right? So you have an open apex. Now, if the open apex is so wide that the canals are divergent, not convergent, but divergent, that is blunderbuss. If the root is almost fully formed, but still the apical foramen is greater than 1 mm in size, it is an open apex, but it's not blunderbuss. Irrespective. So all blunderbuss canals are open apex, yes. Are all open apex blunderbuss? No. Right? Okay. Coming to the more important point right now. What is the method of choice of determining the working length for an open apex case? And that's the paper point method. That's a method of choice for determining working length, and many of you would mark, because the examiner is very smart, he would give you that classic option of radio plus electronic apex locator, right? Don't mark that. The answer is paper point method, right, guys? Primary nahi beta, primary nahi, it's permanent tooth. I mean, open apex can happen in, it's a newly erupted tooth, right? So whether it's a primary tooth, it's a permanent tooth, the root is not yet fully formed. It's an open apex case. Yes. All right, guys. Now you'll ask me, sir, why? Why is it that our radiograph and our electronic apex locator is not that accurate just based on some study? What the study says is that the paper point, you put the paper point inside, and the tip of the paper point where it starts to get wet is basically talking to the periodontal ligament, right? It's getting wet by the tissue fluids. So you're not supposed to go to that length. Just keep it right up to that area where the tip of the paper point starts to get wet. That's a very good method for open apex or immature teeth. It's considered better than the determination by X-ray, apex locator, or a combination. Right? Shelja, we'll talk about that. Yes, you should. All of you should. Even if you have finished your first prof exam, please start preparing for MDS. But anyways, right guys, ये MCQ clear है? That's another MCQ. A very favorite of the AIMS people. I. Oh, method of choice. Okay, sorry, I'll just write method of choice or the best method for determination of WL is working length. Right, beta? Is that fine? Wow, Prashant, what a question. So basically, Cutler method again is not a method there. It's basically a recommendation that you have your apical constriction, which is again anywhere from 0.5 to 1 mm short of the apical foramen. So that's why it's not a method, it's just a guideline. So he says that in older people, as you grow older, there is deposition of secondary extra cementum. So then the distance between the apical constriction and the foramen increases. So it increases say to about, if it's average 0.5 mm for young patients, then it would be 0.75 to 1 mm. And that's the recommendations. That's again not just restricted to apical constriction or apical foramen, it's the relationship between the apical foramen and the apical constriction. Fine, Prashant. I hope, is that an MCQ? If that is, obviously apical constriction. The answer, we are trying to reach the apical constriction. उसमें तो कोई doubt ही नहीं है. The answer is apical constriction, Prashant. Siddharth, you are supposed to use the paper point method after you've extirpated the pulp. And you've ensured that the canal is dry. Obviously. So you can't do it in a weeping canal case. Can't do it when pulp is still there. Yeah. You have to extirpate the pulp. Okay. McQueen, sir, you told. McQueen kya hai, beta? I didn't say McQueen. Nandana, please just check this out. I didn't say McQueen. I don't know. MOCA, method of choice, beta. This is method of choice. Method of choice for determination of working length of open apex cases, paper point. Right? Okay, wonderful. No. No. Not necessarily. Root resorption, not necessarily. You can have some root resorption on the side of the root, not necessarily involving the exact tip of the root. Please don't get confused, guys. Please do not, you should think, you should correlate, but please don't go overboard. Akanksha just told, no, but blunderbuss canal is an open apex, but the dentinal walls are so thin that the walls are diverging towards the apex. So all blunderbuss canals are open apex canals, but all open apex canals are not blunderbuss, right? We'll discuss about this in greater detail when we do trauma. No prerna, root resorption not necessarily happens right at the root tip, leading to an open apex, not necessarily. It can be the side of the root tip, right? Please don't get confused. The word open apex has to be there for the paper point method. All right, shall I proceed? All of you are good till here? Yes, dear. MCQ yahi tha beta. Poonam, this was the MCQ. Yes, guys. Shall I proceed? Now comes the most important. I mean, obviously, all these things that we've discussed are all MCQs, but you have another very important method, guys. Yes, sir. Yes, sir. All good, 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 good. Excellent, guys. Wonderful. Okay, so now you have what is known as, where am I in the scheme of things? I make some, pointers also on the side so that we don't miss a point. This is how a paper point looks like. I mean, all of you know this. I know this. All right. Yeah. So I'm covering everything. Wonderful. Excellent. So now I've come to this important question of determination of working length by the EAL. What is the EAL, guys? Electronic apex locator. Right, guys? Now, what is it? What is the principle? Basically, there is a current, right? In physics, we refer to the current as I, right? V is equal to IR. That's the formula. Now, this current can be a direct current. It can be an alternating current. Is that fine? A direct current would be having some resistance. Resistance in the circuit of an alternating current, you remember 12th class physics, is impedance. All of you know this, right? Now, if the circuit of the apex locator is complete, what do you mean by a complete circuit? What do you mean by a complete circuit, guys? Means the flow of current is more or less unrestricted. You don't have a resistor or capacitor or a specific insulator within the circuit, right? Yes. Then, when the first apex locator was formed, it was shown that when the circuit is complete, then the resistance of the first generation apex locator, which was based on a direct current, was 6.5 kilo ohm. Right? What does this mean? This basically means, guys, that see, I'll show this to you first on the schematic diagram here. You see this? That's the file clip. That's the lip clip. Lip clip is attached to the mucosa, the side angle of the mouth, right? That is the monitor, right? Anode cathode nahi hai beta isme. Now I'll just zoom in this. This is my apex locator, although this is not a direct current base. This is a third generation root ZX. So I'll just zoom this. I know at the level of internship, I don't know what is happening, at what level you are. We did not have access to the apex locators, only the postgraduate students had. So I thought it would be good for your understanding. Okay, if I zoomed in, so I'm switching it on, right? That's the display, right? All of you are able to see the display, guys? Okay. Okay. Before that, so that's the monitor, right? Now, guys, this is the lip clip. This goes inside the angle of the mouth to complete the circuit, right? Yeah. This is root ZX beta. And this is the file clip. This, yeah, I put it on a black background. This is the file clip. I'm pressing it and it clamps the file, right? So you basically put your K file right inside, say a 10 number, 15 number K file inside the canal. In order to complete the circuit, you switch this apex, you first of all switch on this apex locator, right? You put the lip clip at the angle of mouth of the patient. Why? Because mucosa filled with saliva, lined with saliva, which is an electrolyte, completes the circuit. And there's a file clip which you put on the metallic portion of the file, right? The portion of the file that is just coming out of the tooth, right? All of you are with me till now? Right? Now, guys, just see here. See the magic. I don't have a patient right now. I don't have a file there. if I just connect this lip clip with the file clip with the lip clip, the circuit is complete, right? Because it's a metal with metal, right? And you see this beeping, and you see it here. It's showing pa pa pa. It's the alarm has turned on. It's showing it's going beyond the apex. Why? Why, guys? Because the circuit is fully complete. So what does this mean, guys? This basically means that when the circuit is complete, right, there is no resistance, right? There is less resistance, and it is giving you a signal, both auditory as well as visual, that the file is way beyond the apex, right? How does this happen in the tooth? When your file is beyond, now what? Beyond the apical foramen. See, this is an electronic instrument, guys. It doesn't know the apical constriction and the apical foramen. For this, the hard tissue of the tooth, which is, whether it's dentine, whether it's cementum, it's till the time it is inside the canal, till such time this thing is in the file is inside the canal, it is surrounded by an insulator. The apex locator is not that intelligent that it's going to understand what dentine is and what cementum is. ठीक है बेटा? So the zero reading on the apex locator, and that's the MCQ. What does this say? Apical constriction or apical foramen? Apical foramen. You understand? It is only when the file is beyond the apical foramen. Yes, no doubt, the PDL histologically, the PDL starts beyond the apical constriction, right? But anatomically, the file has to be completely out of the canal. And out of the canal does not mean working length. Out of the canal means outside the apical foramen. So the MCQ is zero reading on the apex locator is what? Represents the apical foramen. And many of you mark it as apical constriction. No. Right? So you have to reach that zero reading, and then you have to reduce 0.5 to 1 mm from that length. Say at 21 mm or 22 mm, I reached the zero reading. That's my apical foramen. Then I reduce that length by 0.5 to 1 mm, put the file, take an X-ray, verify. And then, as I said, there's no 100% guarantee that you're still at the working length, but that's one of the best ways. Is that fine, guys? Yeah, thank you. So we are back, right? So that's the clinical oriented questions that are being asked. Nobody in the past 10 years has asked that, the first generation apex locator is a direct current based, but I'm writing it because you should know. The resistance is 6.5 kilo ohm, right? Then what is the second generation, guys? It is based on alternating current. So it's a impedance based. This is resistance based. Akash, that's a practical question. Both are data says that both are equally good. Okay, second generation apex locator, alternating current based, so impedance based, right? Third generation is what the J Morita is, right? Now this is also obviously alternating current based, but two different currents are used, right? So at two different frequency, one current is 0.8 kilohertz and the other is 4 kilohertz. Again, no need to memorize this, just for your knowledge. Saksham, वही तो बता रहा हूँ बेटा. It is not the apical constriction that the apex locator is saying when you are at zero reading. Zero reading is you're right at that point where the canal ends anatomically, right? That's the apical foramen. Because even between the apical constriction and the apical foramen, you're still surrounded by the tooth, right? If not dentine cementum, but that's still an insulator, right? That's the idea, right? What false positive, false negative, Shalini? No. Okay. Right, guys. Please don't overthink this. Just let's just keep this simple. Oh yes, absolutely. A lot of chances, Moksh. I'll tell you, Ritik. I'll tell you the relevant ones, important ones. Okay. So third generation alternating current. Now two different alternating currents are used. And then you calculate the ratio of the impedance. So you calculate impedance 1 at current number 1. You calculate impedance 2 at current number 2. Right, guys? Yes. Oh, guys, please listen to this first, then I'll take the questions. Let me just finish a small topic, right? Then I'll see. Don't worry, Utkarsh. So this is known as the ratio measurement method. Now, why is this so good, guys? This is good because what happens is that even if the canal has got some fluid, say some pulp, some hypochlorite, some saline, some pulpal remnant, then also there is not too much variation in your value. Why? See, because any impedance has got a certain formula, right? If you remember, we are not going to go into the physics, but there's a certain formula, right, which involves, if you remember your physics, some value of dielectric constant, some capacitance, right? Now, in a canal, in one canal, when you're trying to find out the working length, say for example, there is some pulpal tissue, or say for example, forget that, simple, some hypochlorite still left behind, right? The canal is not completely dry. It is going to be having some value of dielectric constant. When you're calculating the impedance at the first current, there would be some value of dielectric constant of the fluid in the numerator. The same fluid, the same value of dielectric constant is there in the denominator. Why? Because only the current is being altered, right? You understand? The case is the same. The canal is the same, right? This gets cancelled. So in the ratio measurement method, even if there is some fluid inside, it won't affect the value. Is that fine, guys? This is an applied MCQ. Yes, Pavitra. I'll tell you what. I'll tell you, dear. Okay. Is that fine? Please listen to this carefully, guys. I'll look at all your questions. Yes. ये समझ आया, this ratio measurement method. Did you get this, guys? Did you get the ratio measurement method, guys? That because of the ratio measurement method, because you're using two different frequencies, two different alternating currents, whatever value of fluid of dielectric constant is there when you're calculating the impedance, your value, final value, is not getting affected because you're taking a ratio. Yeah. Okay. Fine. Let's understand it this way, guys. Okay, guys, I think 3 or 4 people have said repeat, so I'll repeat. There's this big problem with apex locator, especially the first and the second generation. They say that the canal has to be dry. Why? Because whatever value of resistance or impedance in the first and the second generation respectively is there, that value, yeah, that value can affect the result, right? True. Why not? Because your final value, the value of the resistance or the impedance in that same tooth, say if it is having sodium hypochlorite, or if it's dry, or if it has pulpal fluid, that value will vary based on the dielectric constant of that liquid, because the impedance, if you calculate, has, if you remember your 12th, has some complex formula under root dielectric constant square divided by capacitance and so on and so forth, right? So the value will vary. Value would vary because it's the property of the electrolyte or the fluid that is there inside the canal if you haven't tried it. What happens with the third generation apex locator, especially the root ZX? It is based on ratio measurement method. What do you mean by that? You're not relying on one current, you're relying on two currents, two alternating currents at two different frequencies, right? So it's going to be having two different impedance values, but you're taking working length of that same canal, right? So that canal at a given point of time will be having whatever, if it is not dry, if it has say some fluid like hypochlorite, it's going to be having some value of its capacitance, some dielectric constant. Now when I take the value of impedance at frequency 1, the numerator will have some value of dielectric constant, the denominator will have the same value of dielectric constant, they'll cancel each other, the numerator and denominator. 2 upon 2 is 1, 10 upon 10 is 1, 100 upon 100 is 1, right? 1000 upon 1000 is 1. So irrespective of what fluid you have, with the ratio measurement method, cancels out, right? So that's why if you have some fluid inside, no worries. Root ZX is the best, right? In that sense. Is that fine, guys? अब समझ आ गया सबको? Yes. Yes, everyone. I won't go ahead if you don't understand this. This is a concept. Although this concept won't be asked, but they'll ask you. Like a third generation root ZX is based on what? Ratio measurement method. Yes, everybody. Tell me, guys, all of you understood this? Yep. Mini is basically just a small version of this, more handy, but the same principle. Third generation, everything same. And it's slightly cheaper, I think. I prefer the big one. I find that mini very sensitive. Oh, you just apply, take out, Dr. Murari, just take out the pulp first. Use a paper point. If the paper point is still wet, again, use your broach. Take out the pulp some more, irrigate. Again, use your paper point, dry the canal. But as I said, root ZX works fairly well in, even if the canal is not perfectly dry. Obviously, it should not be like filled with, overflowing with hypo or saline, but it works okay. Yeah. Wonderful, guys. Excellent. Bahut badhiya. Yeah, exactly, Pavitra. So in ratio measurement method, some amount of fluid is acceptable. Then you have the fourth generation, the fifth generation, and the sixth generation. Again, they're all based on alternating currents, but it's just that, you know, for example, the fourth generation uses even more frequencies, like 5 different frequencies, and it says that it checks the root mean square value of all the different impedances at all the 5 different frequencies. So it says, the manufacturer says that my method is more accurate. Again, no need to go into too much details. 5th, 6th generation, they just say that our software is better, better, better. Conceptually, these are the questions that are asked. No need to go too much into the details of what exactly the mechanism of a 6th generation apex locator is. It's just that they say that the software is more modern, that's it. But as I said, the gold standard is still good, Akash, keep studying hard. There are, Sammy, nowadays, the same company, J Morita, gives you this Tri-Auto ZX, which has an apex locator incorporated in the endomotor handpiece. I've used it. I don't have it. I've used it. It's also pretty good. So simultaneously, while you're going inside the canal with your file, you get a fair idea of, someone asked me, अच्छा ये देख लो एक बार. Oh, as you go higher, they get more costly. अच्छा someone asked me, sir, ये जो 1, 2, 3 है, on the, I'll just increase the size here. Someone asked me, sir, then what is this 1, 2, 3 on the apex locator? Guys, 1, 2, 3 does not represent you're short of the working length by 1, 2, and 3 respectively. It just gives you a fair idea that your file is advancing into the canal. You understand? So it's like if it's saying 3, right? You have your file in the canal, right? No, dear. I'll tell you which all examples are important. So, guys, if you have a file in the canal and you put your lip clip on the patient's lip and you put the file clip on the file, right? And the reading is at 2. Does that mean you're 2 mm short of the apex? No. No. It's a comparison. Then you again put your file slightly down and it says now 1 mm short. That means the file is, it's not saying 1 mm short of the working length. No. It just simply says the file is on the right track. It's going in deeper inside the canal. That's it. In order to reach the working length, you have to go till that red apex. That is the apical foramen. And then you have to shorten it by 0.5 to 1 mm. And then see, is it showing 0.5 mm short? See, there is a triangle here. In between there's a small triangle on the display. In between, don't worry if you're not able to see it, the small, horizontal mark between the apex and 1 mm short. Right? So you have to go till the red apex, which shows the apical foramen. You have to pull your file back by about 0.5 to 1 mm and then see if it's then it's actually 0.5 to 1 mm short of the apex, which is most likely the apical constriction. You cannot not go till the apex and just say, acha ye to 1 mm short hai, more or less okay, I am somewhere near the apex. No, not at all. All right, guys, is that fine? Swati, why no? Acha, you're saying no to Akanksha. Okay. So I'll tell you, Akanksha, I do recommend a couple of examples, although they haven't, as I said, they haven't come. If you see the diagnostics, they haven't come. Yes, that is known as calibration of the apex locator. It's better. I mean, not overextension to the extent that you're going 2-3 mm beyond the apex, but yes, with your initial file, just go till the apical foramen. Yes, you do. You should. Otherwise, your apex locator gives you false readings. Yes. Yeah. Okay. As I said, someone is asking me, sir, examples. I would recommend a few examples. If you can remember, first generation. Sono Explorer, Ultima, EZ, Apex Finder. Okay. Second generation, Sono Explorer again. Now that's a controversy because Ingle themselves, the textbook of Ingle, it itself has put Sono Explorer in first and second generation. I don't know why. Probably it's the same version, the second version, which came 2-3 years later. For example, Sono Explorer was, I think, introduced in 1970, and then 1971 version was probably the second generation. If the controversy is, sir, Sono Explorer aa gaya, what is the answer? Is it first generation, second generation? Pavitra, third generation. Root ZX, dear. Root ZX is the third generation apex locator. So I don't know, guys. This question should not come. This is a big controversy. Ingle writes it. What do I say? Okay. What about third generation? You have APIT, APIT, commercially known as Endex, ENDEX, and obviously Root ZX. Then you have Endo Analyzer Model 8005. Again, as I said, yeah. As I said, not very important examples. We will probably share this PDF also, so you can always revise this. Fourth generation, as I said, again, they're all using alternating current. It is saying that I use a better algorithm. I use 5 different alternating currents, and I take the root mean square value. Example of fourth generation is Rapex 4, and in 2003 there was Elements Diagnostic Unit and its associated apex locator, electronic apex locator. Fifth generation, Joypex 5. Sixth generation is also known as adaptive apex locator, Rapex 6. No need to go into the details of the mechanisms, guys. Yeah, it's Shweta. Yes, the zero reading on the apex locator is the apical foramen, and if the reading is going even beyond that, then you're beyond the apical foramen, right? Yeah. So, guys, what are the apart from the working length? Basically, what the apex locator is determining? It's determining that you've completed the circuit. You are in the soft tissue. So, one soft tissue is the lip clip. Yes, Pavitra. Zero reading is apical foramen. So, guys, so what exactly is the apex locator determining? Is it determining the working length? No, it does not know. It's just a machine, right? It's basically telling you that the circuit is complete. When is the circuit complete? When you have very less impedance or resistance value, very minimal, right? Say for example, in first generation, it's 6.5 kilo. You understand? Any electrical circuit, even if it is full of conductors in between, will have some impedance value, right? So that minimal impedance value, which is fed into the head, which is fed into the software, is when it reaches that, it starts beeping, it starts saying zero reading, the circuit is complete. That means on the one hand you have the mucosa, and on the other hand you've reached the PDL or the gingival sulcus. So that happens when you are in the apical foramen, or when your file is communicating with the PDL in a root fracture or in a perforation case, right? So apex locators are used to determine what all: working length, root fractures, perforations. Is that right, guys? So that's another MCQ. Is that right, guys? Are you all good now with working length? Can all of you confidently now say that you know something about working length? Yes, guys? That's absolutely necessary, dear. Saliva is responsible. That's the electrolyte, right? Just like tissue fluid in the PDL. If that is not there, how will the circuit get complete? Yes? Yes, guys? Dear, basically the apex locator is reaching the PDL, it starts beeping. So in perforation, you're reaching the PDL. In root fracture, you're reaching the PDL. In apical foramen and just beyond it, you're reaching the PDL. The apex locator does not know what a working length is, right? This guy is not listening to our class, right? Yes. Yes, guys. Yes, Bhartiya. They're fine. Guys, are all of you good? Are we good till now? Tactile feedback method, we don't use it. You know, you're taking a file, you're feeling the constriction. That constriction can be somewhere in the middle third of the canal also. So it's no longer recommended. You still use it to verify, you know, as you get more experienced, you do get some get some feel of the apical constriction, but that's not a predictable method, not recommended. Right. You can use it as an adjunct to both the apex locator and the radiograph, but you cannot depend on it. Okay, guys. So working length determination is finished. We have done all the possible MCQs that have come, and I think that should be it for our non-DBMCI friends who are streaming, who's seeing this live stream on YouTube. And I think we're going to go back to all of our DBMCI students. We'll take a short break, right? 10-15 minutes break, guys. Go and take a breather, and then I'll see you on the other side with diagnosis and cardiology and so on and so forth. Very interesting topic, actually, that I've put in. Prerna, you don't want to enlarge your apical foramen. You're going to transport it otherwise. There's what is known as apical zipping. zipping will happen. You don't want to do that, right? Apical sensitivity is when the patient says, pain, because PDL is fully innervated, right? So the pain can be because of pulpal remnants also. So again, not a great method. And you don't want to give pain, right, to the patient. You're doing your root canal procedure under local anesthesia. The patient will say, what, you're experimenting on me? You first give me pain. I jump in the chair. Why have I come to you? Right? So again, not a recommended method. 10, 15 minutes, dear, 15 minutes. So I'll see you till in between 7:40 to 7:45. Start at 7:45, right? I think so, yeah. This is on YouTube. So this will remain on YouTube, I think. Yes, I'm sure it will. Right, guys? Okay, great. I'll see you then. I break YouTube.